Hi, Clay Angel, Hospital Medicine, President-elect, American Delirium Society. I like to connect via a story. It's kind of the beginning of my understanding of the impact of delirium on clinical care for a hospital medicine physician. So this story begins September 21st, 2009. It was a busy admitting shift, and I'll always remember a patient named Jim who I was asked to consult on and admit that day. He seemed like a standard pulmonary patient. He presented with borderline severe COPD exacerbation, bronchitis, and lots of arthritis and joint pain. Jim was a charming man in his early 70s. He loved fishing in Alaska and spending time outdoors. I remember signing Jim's case out to a colleague once I finished the admission. My instructions were straightforward: antibiotics, steroids, breathing treatments, pain meds, and consider a CT scan for further evaluation if he's not better by the next day or so. I remember saying, "He's easy, should only be here a few days max." Jim's stay lasted nearly 3 months. A week following admission, he just wasn't improving as we expected. A CT scan showed significant lung disease and likely abscess formation. The thoracic surgeon recommended a video-assisted thoracoscopic procedure to address the pulmonary abscess. After surgery, Jim was placed in the ICU for observation and was noted to be a little confused. Jim was in the ICU for weeks. Treatment involved restraints, IV drips, lap belts, Ativan, Haldol, and sitters. He was eventually transferred to a med-surg bed with a 24-hour sitter. We did the best we could on the med-surg unit, but most of the time, Jim thought he was in a casino and that it was sometime in the late 1980s. During a walk around the unit with the sitter late one evening, he suddenly broke free. He ran for a nearby exit door, which led to a stairway, and fell down a flight of stairs. Code blue, stat head CT, intracerebral bleed, luckily non-surgical, and another month in the ICU. After a long and difficult journey, Jim finally transferred to a nursing facility in late December and went home with assistance shortly thereafter. But Jim's story doesn't end there. I had assumed that his delirium was multifactorial and likely caused by his prolonged hospital stay, the ICU, infection, and narcotics. As it happened, I was on call several months later when he presented to the ER with another COPD exacerbation. We had no tools or interventions in place for delirium at that time, and I wasn't fully aware of my role in possibly exacerbating his condition. He received steroids that night along with the quinolone antibiotic. Guess what happened? Within 6 hours of admission, he was acutely delirious again. But this time, it only took 15 days for Jim to mentally clear and go home. This was spring of 2010, and our conversations about delirium were in full swing, mostly prompted by this experience that affected nearly everyone who worked in the med-surg or ICU settings. We all knew Jim. Fast forward 1 year later, Jim was electively admitted by orthopedic surgery for a left shoulder replacement. By this time, we had basic protocols in place and assessment tools for delirium. We also knew which meds not to give, especially no steroids for him, if we could avoid it. We kept his room as quiet as possible, prescribed trazodone instead of Ambien when he wanted a sleeping pill, and we did move him from room to room. He was out of the hospital in 3 days without ever developing delirium. This was when we knew we were onto something with our systematic approach to standardized management of delirium. He was admitted again for an elective right shoulder replacement a few months later with the same result, in and out. One of my favorite analogies on delirium is that managing this condition is like trying to avoid a head-on collision during a car accident. When Jim first arrived at our hospital, we all suffered a head-on accident. On the second presentation, it was more of a side swipe, and on the third and fourth admissions, we avoided the accident altogether. A relentless team approach and a stage 7 electronic medical record are absolutely necessary to ensure success. We believe that this technology allows for delirium management because we can see real-time medication lists, lab trends, and behavioral assessments. This allows us to implement protocols and standardized order sets that ensure a more consistent approach with consistent actions without a specific expert being present. With all these tools, you can actually avoid delirium altogether. So thank you for allowing me your time on World Delirium Awareness Day. Thank you all for all that you do. Hopefully we can continue to improve and raise awareness for delirium throughout our countries and the world.